Oh, I'm glad to hear. So I just quickly introduced the reason why we're here, and that we're looking at a webinar session on stroke management. So the focus areas are the early warning signs and how physiotherapy can help in stroke rehabilitation. And I said to lead us on the sessions, we have our very own physiotherapist, Chimaobi Ezema. He's the team lead at the Lily Wellness Center. And we also have Dr. Emagboron Solomon. He's a consultant neurologist here at Lily Hospitals. We'd like to join you all to prepare your questions and concerns because there's going to be a question and answer following the presentation. We would be engaging those concerns and questions just as the presentations are done. Also, please do share the link, the webinar link, with your loved ones, people whom you would like to benefit from this very important information, so they can join the call and also get insights into stroke management. Thank you all for joining the call. Please, if you have people around you who are yet to join, we would like that you also reach out to them and get them to join the call. So just as we begin, I'd like to bring up our very first facilitator, that's physiotherapist Chimaobi Ezema, to take us on the F.A.S.T discussion. Thank you.
Hope you can see my slide, right?
You can see your slide.
Yes, we can see your slide.
You can begin.
All right. As earlier mentioned, today we'll be looking at the role of physiotherapy in stroke rehabilitation, the goals and technique. Stroke is a medical condition that occurs when there is hemorrhage, that is bleeding in the brain, or there is a shortage of blood supply to the brain as a result of blockage. And this results in death of brain cells. Functionally, the brain is in charge of every movement that takes place in our body. It controls the sensation, the speech, and balance. But in case of stroke, when stroke occurs, some of these functions performed by the part of the brain that is affected is impaired. Functions such as movements, speech, sensation, balance, or the emotional part of our body is being affected. By reports, aside from heart disease and cancer, stroke is the third cause of death worldwide, and it also contributes to the serious long-term disability worldwide. When stroke occurs, it reduces mobility in an individual that is affected. And this is as a result of the fact that the brain is in charge of every movement that occurs in our body. And it has been reported that in more than half of stroke survivors, age 60 and above, 60 to 65, have more risk of their mobility being reduced. More male than female have been reported to have stroke, and female have reported to die of stroke more than male. We are still going to look into this and reasons why more male suffer from stroke compared to female gender. In terms of prognosis, that's the level of recovery that is reserved after stroke. This is dependent on the level of brain damage. The brain is a tissue and plays a very vital part in our body. So the level of damage on the brain is a factor for recovery. Also, the types of stroke. We have ischemic stroke and we have hemorrhagic stroke. In the case of ischemic stroke is where there is shortage of blood supply to the brain, and that of hemorrhagic stroke is where bleeding occurs in the brain cells as a result of increase in pressure. The type of stroke that is more severe is the hemorrhagic stroke, and which accounts for about 13% of stroke that occurs in the world, unlike the ischemic stroke that occurs for about 87% of stroke. And the severity is more during hemorrhagic stroke, which is bleeding. Then when the care is being initiated and the continuity of care after stroke, the intervention that is carried out when stroke starts can also be a prognosis, can also be an added advantage for recovery. Age have also been identified as one of the prognoses for stroke. Adults recover faster than the elderly when stroke occurs. And this is because every 10 years of our life, there is an increase in the risk of having stroke. Also, the stage, the type of stroke, whether it is a repeat stroke or a first stroke, have a factor to play in recovery. Those who have first stroke have advantage of more recovery. But if it is a repeat stroke, a second stroke strike, or a third stroke strike, this can cause more severity and takes longer time for recovery to occur. Equally, our health-seeking behavior is also a factor that can lead to recovery. If you are a kind that seek for health advice, that go for annual medical check, that is religious with your medication, after stroke, you have more advantage of recovery. There are measurable neurological and functional recovery that is also available in the first months after stroke. This is because the first 1 month of stroke is the best time to recover from stroke. After first month, second month, third month, the severity and the duration of recovery will take longer time, unlike the first month if properly managed. Late recovery is seen in chronic stage when an individual has to undergo an extensive functional rehabilitation, especially in those that have a chronic severe stroke challenge. In Nigeria, there is a 30 days case fatality rate, which is as high as 40%. And this has been reported over time in Nigeria. As soon as stroke occurs, when is the best time to start physiotherapy? Physiotherapists are one of the key professionals in healthcare delivery that is involved in stroke rehabilitation. They work as an interdisciplinary team alongside the neurologist, which is a general practitioner, the nurses, the exercise physiologist, the speech therapist, and the occupational therapist. They form what is called rehabilitation team for management of stroke. And physiotherapists play a very vital role in recovery. We are to start physiotherapy for a stroke patient 24 to 48 hours of onset of stroke, unless there is a medical challenge, such as the patient is still not medically fit to embark on physiotherapy, or that the patient is semi-unconscious, or that the patient is unconscious and need a respiratory attention to enable blood, air and oxygen flow to the brain, and also as an adjunct to support the brain in recovery. However, immediately we have initiated physiotherapy within 24 hours of onset of stroke. It is expected that within 45 minutes that a physiotherapist have to assess a stroke patient in the first 1 week and offer 45 minutes of daily physiotherapy to such individual. The aim of this is to support early discharge if patient is in the hospital, if patient is hospitalized, and also to encourage continuity of care. After stroke, there are challenges that are encountered by stroke survivors. and it comes in form of deficit. One, there is difficulty and inability to use the affected side of the body. In stroke, the brain is divided into two halves, the left hemisphere and the right hemisphere. And the right side of the body controls what happens to the left side of the body, while the right side of the body controls what happens at the left side of the body. So when stroke occurs, there is difficulty and inability to use the affected side of the body. There is challenge in grip, there is challenge in writing, feeding, and also personal hygiene. Equally, one of the challenges encountered by stroke survivors are difficulties and inability to walk, sit, or stand. They struggle a lot to move from one position to another. There is equally loss of balance through coordination. That's what we call pushing syndrome. Most stroke survivors, they tend to align outside the gravity, outside the midline. The affected side tends to push away to the unaffected side, thereby causing the patient to lose balance and coordination while sitting, while standing, and while walking. Also, we have joint stiffness through pain. This occurs mainly at the knee, at the shoulder, and back. This is because the muscles that are supposed to hold the joint in place, the tone of the muscle have changed. And as a result of that, there is high increase in what is called shoulder dislocation or shoulder subluxation. And this can give rise to pain. There is speech and swallowing difficulty that is also noticed when someone has stroke. And this is as a result of the part of the brain that is affected. If it is the left hemisphere of the brain that contains the speech center, such an individual will have a speech impairment challenge. Overall, there is a reduced self-perception in stroke patients. Such an individual perceives himself differently, knowing fully well that he's into another aspect of life where he or she cannot help him or herself. The general quality of life is reduced. They tend to isolate, they tend to withdraw from the society, thereby reducing their self-esteem and perfect perception. In reasoning, there is a cognitive impairment, the way they reason, the way they communicate, the way they memorize things that is happening around them is equally a challenge that such an individual passes through once there is stroke that is being diagnosed. Equally, we have noticed that a lot of stroke patients are confused, especially those from the age of 60 and above, and they are easily fatigued. At every point in time, they find it difficult to participate in the activity of daily living as a result of no energy to carry out a task. In the long run, we are going to look at the reasons why this fatigue is part of the challenge that stroke survivors suffer. One of the goals of physiotherapy in stroke management is dependent on the stage, whether the stroke is an acute, whether it's subacute or a chronic stage. Depending on when stroke survivor is referred to see a physiotherapist or when such an individual have seek for physiotherapy management, will determine the goal of the physiotherapist. The first is to establish an assessment. This assessment will give us a problem list of the challenge that patients that is peculiar to that particular individual. In this goal, we have what is called the short-term goal. The short-term goal is geared towards educating the patient and the family, because the family and the patients have a key role to play in this condition. There is a lot of empathy that is needed from family carers, from friends, from the children, from the husband, from the wife. It is at this stage that they need more of this encouragement. So the patients, likewise the family, are to be properly educated on the journey what caused the stroke, and the rehabilitation protocol that they are going to embark on. It's a journey of the strong. It's a journey that involves collaboration. Patients immediately after stroke have to resume what we call mobilization and out of bed activity. The aim here is to mobilize patients out of bed, such as teaching patients or the caregiver how to transfer from bed to chair, from sitting to lying, from lying to sitting, from sitting to standing. There is a technique for this, and we're going to look at it as we progress. The aim of this mobilization outside the bed is to prevent the conditioning, because the more you lie down on the bed, the more your body becomes weak, the more your respiratory capacity goes down, your inability to breathe and take in more air is another challenge that can cause a stroke patient to become more and more weak. Generally, as patient is hospitalized, we aim at supporting the other multidisciplinary team, the doctors, the nurses, to support this individual for early discharge back to their home. And when they are discharged back to the home, studies have shown that at home, at a convenience, patients tend to recover better than when they're in a hospital environment. Looking at the long-term goal of physiotherapy, we aim to return back the patients close to the pre-incident states, that's before the onset of stroke, such as independent sitting, standing and walking, increased self-perception, having good balance and cognition. This is our long-term goal that we're going to tailor with the individual to return to this level. And one of the priorities of stroke survivors is to go back to work, to enable them continue with their activity of daily living and as well perform their daily tasks as assigned to them in their various offices. The role of physiotherapy in stroke rehabilitation comes with a goal statement, and that goal statement is to help stroke survivors restore the physical acts and skills that they need for daily activity, such as getting in and out of bed, transferring from a chair to a bed, standing from sitting, balance and coordination, being able to walk independently. In this goal, the statement is geared at, okay, the first 1 week of patient admission, we aim to get patients in and out of bed, either with assistance of one or independently. We also aim to ensure that patients can transfer from either from bed to wheelchair or from wheelchair to bed. Teaching the patients, likewise the caregivers, on this part is our goal statement. A good understanding of the role of physiotherapy in stroke rehabilitation will lead us to looking at how we work and how we work after stroke. Walking is a neuromuscular activity. And for one to walk independently, there is a success that you have to embark on, and that is to have a basic rhythm, support and proportion that will be coming from your lower limbs, and then a dynamic balance that will give you room to move from one place to another. If you look at the pictures on the screen, you see a young man walking, and you can see the role the hand is playing, the role the legs is playing, when the toe is off, when the heel is off. This is a normal walking pattern for every individual. However, after stroke, there is a significant deficit that distorts the normal walking pattern, such that there is a decreased extension at the hip. The hip cannot extend properly, and the pelvis tends to go downward. The knee cannot flex. Most stroke patients find it difficult to flex their knee. They rather assume more of knee extension depending on the challenge and the stage of the individual. There is lack of knee extension too. Decreased plantar flexion, they neglect one part of the body. That affected side of the body, the individual tends to neglect it and concentrate more on the affected side, which cannot help them. And this is one of the challenge stroke patients have, neglect. They neglect the side that is good and move to the side that is bad. There is a decreased hip and knee flexion, decreased dorsiflexion and ankle dorsiflexion. These are observable deficits that occurs in stroke patients, which the physiotherapists have a strong role in restoring such individual back to normal way of working. Generally, the role of physiotherapy in stroke management is to support the disciplinary team in discharging these patients as early as possible from the hospital. To facilitate relearning of movement, because after stroke, a lot of movement is lost, such as inability to roll. You see patients struggling to roll, turn from one side of the bed, to sit independently, stand and walk. So another whole role we have here is to enhance adaptation, which involves working with the occupational therapists to ensure that the home is adapted such that such stroke patients can climb the stairs, can make use of rails. In the toilet, in the bedroom, there will be a ramp and rails that will enable such individual to still perform his daily activity. We also aim to prevent secondary complication. There is a lot of complication that occurs in stroke patients. When they are walking, you see an uneven step and stride length. They tend to spend more time when they are in double support. The speed of walk is reduced significantly. They hardly use the arm for support while walking. And there is a decrease in the stride and step length. These are some of the complications that affect stroke patients that they find it difficult to move. And those who are able to move with the support of a walking stick or a tripod, they assume an abnormal pattern, which can lead to stiffening of the joints, which can lead to spasticity and cause the patient not to move at the same velocity that he or she is moving before the onset of stroke. We also aim to maintain the ability and function of such stroke individual. Abilities such as writing, such as typing, such as using their hand to feed, to dress. We aim at a specific tailored exercises that will help to restore this function. And equally, to return such individual to work. This will involve an evaluation that is called functional capacity evaluation to enable us to recommend the type of work that this stroke survivor have to start with immediately they resume work. And this has to be done in collaboration with the occupational health physician, with the occupational therapist, with the speech therapist. Everybody has to come to the table and make their recommendation. We have several techniques that physiotherapists use for management of stroke. And it will interest you to know that at the onset of stroke, physiotherapy intervention is very, very paramount. First is in positioning of patients. How do you position a stroke patient? At the onset, for sitting down, for lying down, and while standing. These are key to restoring movement. Immediately, stroke patient is admitted in the hospital, physiotherapists have to assess and ensure that within 4 hours of arrival at the hospital, patient is properly positioned. And this involves the use of support devices such as the lamp tray, which you can see at the picture on the screen, how pillow can be placed at the knee, how it can be placed at the neck, how it can be placed at the hand, and when such patient is sitting. These are very paramount, and caregivers, likewise, the family members, has to be educated properly on correct manual handling and the positioning of this patient, even when discharged. So position does a lot of magic. It helps to improve the cardiopulmonary endurance. It helps the patient to take in a deep breath and also enable the diaphragm to contract very well, such that the lungs can accommodate more air and reduce this impact of fatigue. Too much lying down contributes to the reason why stroke patients are always fatigued. But when you change position from lying to sitting, you give the lungs opportunity to expand and accommodate more air, thereby giving such individual the endurance to perform more activity. Another technique employed by physiotherapists for management of stroke individual is in early mobilization. There is always an emphasis that immediately within 24 hours that stroke patient is admitted or stroke has been identified in an individual, you have to commence mobilization. Mobilization will mean here is out of bed activity. That same activity you have been doing before the onset of stroke has to commence. And unless there is a medical history that states that this patient is not stable to resume this out of bed activity, some of these conditions can be as a result of the fact that the blood pressure has not yet been controlled to the level where he or she can start physiotherapy, or that the patient has to be transfused with blood to give energy, or the patient is on oxygen to supplement the brain from the one it has, or patient has to go for an MRI to have a diagnostic picture of what is going on in the brain. Aside this, once this patient has been confirmed fit within 24 to 84 hours, he has to commence out of bed activity. Studies have shown that early mobilization is key to recovery. So intensive out of bed activity is very paramount, but is not recommended within 24 hours if such individual is not stable. Aside from early mobilization, we have noticed that stroke patients struggle a lot with balance. Trying to stand, trying to sit, trying to lie down on the bed. They have high risk of fall. So it is the role and one of the intervention of physiotherapists to progressively embark on a balance and coordination training for stroke patients. It has been noted that the trunk of stroke patients are always weak, and that is because of the position, the hemileglet and the pushing syndrome they normally battle with. The trunk of the affected side is weak, so we embark on a trunk stability exercises to improve the dynamic balance in both sitting and standing. There are what we call 30 seconds sit to stand exercise. We are to task such individual to do exercises that will involve him or her to stand and sit within 30 seconds. Ability to pass this test or this exercise will lead to another one that we call tandem to huddle walk. If you can stand within 30 seconds, we'll be able to initiate another treatment modality, that is tandem walk or huddle walk. This helps to give balance. This helps to give coordination for stroke patients. It's progressive. What you did in the first week of your survival is different from what you're going to do in the second week, the third week, the fourth week, in the next 1 month. That is why it is a progressive balance and coordination training. is very important. Once you are able to control this balance, walking becomes easier, sitting becomes easier, risk of fall is drastically reduced. As we are into a progressive balance and coordination training, we are looking at mobility and gait exercises that will enable the patient to either move independently or with assistance of cane, walker, or tripod cane, depending on the level of prognosis we have made. Will determine the type of walking aid that will be recommended by physiotherapist. Now, what we call circuit class therapy, it is focused on overcoming a ground walking challenge. Most stroke patients are struggling to clear the foot off the ground. And the circuit class therapy that involves a gait training exercise is what a stroke patient has to pass through. The truth is that stroke recovery, stroke rehabilitation is a journey of the strong. You have to be prepared, you have to be emotionally stable to enable you come back to your state, because we are going to task you according to your level of recovery. Another exercise to embark on is what we call time up and go exercise. It can be done using a walker, it can be done on a treadmill, it can be done on a horizontal ground. This exercise will be timed. 5 seconds, 10 seconds, 20 seconds. To embark on a time up and go exercise, move from one end and come back either with aid or without assistance. The ability to do this will also lead us to a 10-minute walk exercise that will help to improve your endurance and retrain your gait. If you're struggling to embark independently on movement, we use what we call parallel bar to mirror walk. In the parallel bar, a mirror is standing in front of you. As you're walking, you'll be looking at yourself at the mirror for a biofeedback to give you a good understanding whether you are performing or moving in the right direction or not. These are the modalities, these are the techniques used by physiotherapists to retrain you so that you can walk independently or with assistance after stroke. More still, a lot of stroke patients, because of alteration in muscle tone, they need strengthening and range of motion exercises. This will enable them to have good strength, good balance, to embark on a training that will give them an overall strength to work in the society during recovery and after recovery. This includes a one-leg stance exercise. Physiotherapists will task you to do a lot of one-leg stance, to bear weight, to strengthen that particular side of the body that is weak. We have a parallel bar, we have a wall bar that this can be carried out. And that's why it's advisable to always visit a physiotherapy center, because that's where this strengthening and range of motion exercises is properly done. We'll task you to do a half squat exercise, a resistance active exercises. This is geared towards strengthening your lower limbs and the upper limb. We will train you on stair climbing. As you're climbing the stair, you are strengthening the limb that is affected. There is a protocol for this, depending on your level of recovery, that will give us a yardstick on how to embark on your strengthening exercises, using either bridging exercises or resistance step exercises or recumbent ergometer, a static bicycle that will help to restore and maintain the range of motion applicable in your joints. Also, we encourage stroke patients, especially those at the level where their joint is becoming very, very stiff, or they are finding it difficult to grip, or they are finding it very difficult to open their fingers, or the position of their elbow, the shoulder have come closer to the body. We use what is called constraint-induced movement therapy to discourage such abnormal pattern from occurring. And this have shown that about 85% of stroke survivors experience altered arm function. And 40% of individuals being affected by long-term upper limb dysfunction, we encourage them to carry out a repetitive and task-specific exercises. A glance at the picture on the screen, you will see how the good hand is restricted. The brain peaks faster. And whenever you ask a stroke individual to drink water with the affected hand or to eat food with the affected hand, they quickly run to the good one with some belief that the affected one cannot do it. But neuroplasticity have shown that a particular part of the body, the brain, can be trained to take up a role. So when there is a constraint on the good side of the body, tasking the bad side, that's the affected side, to carry out a specific repetitive task, this is an added advantage and helps in recovery of stroke patients. Asking them to use that particular hand to drink water, to eat fruit, to eat food, to dress and wear their clothes is a repetitive task that we encourage during rehabilitation. Also, we have an adjunct therapy that we use to prevent abnormal stiffness of the joint. Some stroke patients, especially those in their chronic phase, those that have suffered from stroke after 6 months, a year, 2 years, and above, they tend to have what is called spasticity. The bones, the joints become so stiff that they find it difficult to open their arms, open their fingers, to grip, to lift their hand up. Some of them have what we call shoulder subluxation. Because of the heaviness of the affected side, the joint of the shoulder, the humerus, tends to pull away from the sockets. So some of these orthotics are used. We encourage stroke survivors to use them to prevent this abnormal spasticity, abnormal stiffness of the joints from happening, while we work on restoring them back to function. Stroke patients have prioritized returning of work. And as physiotherapists, one of our role is also to assist them go back to their way of life, which is going back to the work they are doing, either an office work or a field work. So this will also help us to work as a team, as an interdisciplinary team. We're going to have a joint review with the occupational therapist or the occupational health physician, the speech therapist, the neurologist. They come together to review this individual, look into the drugs he's taking, have a repeat MRI or CT scan to look at the picture of the brain. If it is hemorrhage that caused the stroke, the picture of the MRI will tell us whether the brain tissue have dried up. If it's a shortage of blood supply, then for instance, if there is an embolus of fat that's blocked it, have it been lysed, have it been removed, have it been unblocked such that blood can flow back to the brain. So a joint review assessment will now need physiotherapists to the final stage of evaluation, which is what we call functional capacity evaluation. This test involves a test for mobility, a test for dynamic strength, a test for balance and coordination, a test for precision, after which we'll make a recommendation and send to the individual's workplace to gradually reintegrate the stroke survivor back to his office, gradually the task he or she can perform and the one he cannot perform at that stage. By so doing it, the stroke survivor will gradually move back to his work. And we also encourage that before returning to work, and even while you have returned to work, there should be a routine blood pressure evaluation check. Monthly, on a quarterly, annually, we encourage you to see your physician regularly and see your physiotherapist regularly for a routine assessment to prevent repeat stroke. In conclusion, I'll be concluding with the risk factors for stroke. A lot of us are at risk of having stroke, even at this stage. You must not be at the age of 60 and above to have stroke. As earlier mentioned, every 10 years of our life you have lived, you are at risk of developing stroke. Risk of stroke can be modifiable. That means you can control it. And some is not modifiable. Those modifiable ones include high blood pressure, obesity, that's having an excess weight, you are overweight. The ideal weight is 18 to 25, having a BMI, a body mass index of 18 to 25. On 25, you are above the normal range. So you will have to control your weight. Then those who have had stroke, we encourage them to do the needful so that you will not have a repeat stroke, because it's also a risk. Having had stroke is already a risk of having a repeat stroke. And those who are in the habit of smoking, smoking can contribute to stroke. It narrows, it causes atherosclerosis, it narrows the blood vessels. And when it narrows, the blood supply to the brain is reduced and oxygen supply to the brain is affected. And this can lead to ischemic stroke. The same applies to alcohol. Excess alcohol is a risk factor for developing stroke. It will interest you to know that alcohol on a high level is not good and can lead to stroke because it has an altered function to the blood vessels. Why some is also non-modifiable? Age. Every day we continue to age. Today you are +1, tomorrow you are +1, next tomorrow you are +1 is a factor that you cannot modify. So the fact that you are aging every day is a risk factor. So it's an ideal thing that you watch at every age. What are the necessary things you need to do to prevent stroke? Gender. As earlier mentioned, I said that more male are at the risk of having stroke than female. And this is because in our environment, men takes to alcohol more, they takes to smoking. The study have shown that they are more nonchalant and non-religious to their blood pressure medication evaluation. Most of them are not compliant with instructions given to them whenever they visit the hospital. However, more women die of stroke than men. This is because women are more emotional. They feel their self-perception is altered more during stroke. And they need a lot of motivation, a lot of encouragement to enable them come out. While majority of them are stuck in that condition. So they hardly make it out of the environment when they have stroke. Your health-seeking behavior is also a priority. So the way you seek can also be a risk factor. So we encourage that at every point in life, at every stage of your life, and whenever and wherever you notice signs of stroke, that a physiotherapy has to be involved. You have to see a doctor which one of my colleagues here is going to highlight on the warning signs that have to call for your attention immediately to see a physician to know the best form of intervention to start with to enable physiotherapy coming for stroke management. Thank you very much for listening. We are open to questions, recommendations, and contribution.
Much, Mr. Chimaobi, physiotherapist Chimaobi, for taking us on that very extensive session. Early warning signs and symptoms, and then the role of physiotherapy in stroke rehabilitation. Thank you for leading us through that session. We would love to organize the questions. So just after Dr. Solomon, we would just go straight away into the Q&A session. But very quickly, I would like to welcome Dr. Solomon Emagboron. He's our consultant neurologist here at Lily Hospitals. He's going to be leading us furthermore on this discussion, and good to note, he's going to be taking us further from where physiotherapist Chimaobi has stopped on how we can furthermore manage this process. Thank you so much. Dr. Solomon, please, if you're on this call, I would like for you to come up right away and begin your presentation. Thank you. Please, are you on the call? Are you on the call, sir?
He's on the call, but it's like he just dropped off. So I'll try to reach him. Okay, it's coming on.
Hello, good morning.
Hi, good morning, Dr. Solomon. Good to have you here on the call, sir.
Okay.
Yes, sir. So we would like to receive your session right away. I see you talking on the early warning signs and then the symptoms of stroke. We are very happy to have you bring that wealth of knowledge to us.
Okay, I'm just trying to share my slides. Can I be heard clearly?
Yes, I can hear you very clearly. I can hear you very clearly.
Yes, we can.
Thank you, sir. Okay, so whilst we expect him to get his slide or get ready for the presentation, Dr. Solomon is a consultant neurologist here at Lily Hospitals, and he's just going to be taking us on the early warning signs and symptoms of stroke. I'd like for us to be open to receiving that which he has to bring and prepare our concerns and questions in this wise. Yes, thank you so much. Dr. Solomon, over to you. Thank you.
Okay, can you see my slides?
Doctor,
Yes,
we
we
can
can.
see your slide. Yeah, we can see your slide. Thank you.
Okay, good morning all. Dr. Solomon Emagboron, neurologist at Lily Hospitals. I want to first thank the physiotherapist, Chimaobi, for an excellent presentation. His presentation has greatly simplified most of the clinical aspects that I was going to talk about in this discussion of stroke. Yeah, at Lily Hospitals, we see all medical conditions, brain disorders, not just stroke, see headaches, dementia, epilepsy, and all other brain disorders. But in particular, today, we're talking about stroke. So in terms of when should the patient present to the hospital? By way of introduction, I would like to say that stroke, the word stroke came up from strike, which in the time of Hippocrates means like something happened so fast, as if the patient was struck. Like so, it looked from the name, it looked like something spiritual. So culturally, spiritually, most cultures are afraid of this condition. So even the white people that came up with the naming of stroke, they made the name, or the name was derived from to be struck by something. So it has a spiritual significance. And it also means that its occurrence is sudden. It just comes up suddenly out of nowhere. Someone is fine, hale and hearty. All of a sudden, he can't speak or he can't move his hand or something. So it looks, it comes up so fast. Just to say that stroke is the second leading cause of death worldwide, just after ischemic heart disease, which is heart attack. So heart attack is number one cause of death. Brain attack, another name for stroke, is number two cause of death worldwide. So because of the cultural significance of stroke, well, we say in medicine and in neurology that stroke is the easiest condition to diagnose, such a way that a person suffering a stroke, even the child, his son or his daughter, is able to tell the person that, daddy, your mouth is bent to one side, what's wrong? So even the daughter or the son, the wife, spouse, is able to make a diagnosis of stroke right from the home. Or even a colleague at work is able to notice it and say, young man, what's going on? Your face looks abnormal. You should take a look at the mirror. So, in general, medically, we sometimes tease ourselves and say stroke can be diagnosed by a market woman. So, stroke is really easy to diagnose. Um, there is a mnemonic that helps to formalize the process of out of hospital diagnosis in such a way that because of the significance of stroke, the importance of the brain, it is said that the faster you know that someone is suffering a stroke, the better for the person. So that's how the FAST mnemonic came up, in which case, if you follow the mnemonic, face, arm, speech, time, you look at the person's face. Is it bent to one side? Is one side of the face drooping? Is one side hanging downwards? Or the face just looks abnormal from what it's supposed to look. So that's a warning. Then you look at his arms, you say, oh, sir, can you raise your arms? If it's a spouse or a dad, say, oh, he might already have noticed that while trying to pick up his maybe a cup of water that morning, the object falls from his hand, or he's trying to get his toothbrush and is not able to brush his teeth. So a couple of our patients come in, their children have noticed it, or they say, oh, I got to work and I cannot write. I could not sign my signature. So affectation of the face, the arm. Then the speech, some of them may not be able to communicate at all. Some can communicate, but the speech appears slurred. You say, we can't hear what you're saying. We can't hear what you're saying. Or he's saying something completely different. So that's for the S part of the mnemonic. Then the T stands for time. Time is very important in stroke. The earlier a patient presents, the better for the patient. So in terms of percentage, the commonest presentation for stroke, apart from the face, arm, and speech, also issues with balance. So we see this a lot in elderly people. We say, oh, mama woke up in the morning and she could not get out of bed. So actually, from the literature, balance is often the most common presentation, inability to. So most strokes we say happen at night. We call them wake up strokes. So the patient wakes up, cannot get up from the bed, or struggles to get up from the bed, or gets up and falls to one side. So problems of balance occur in as much as 83% of stroke patients. So sometimes they are misdiagnosed. They say, oh, maybe it's just tired, or maybe it's mama, or it's papa, maybe it's arthritis. So maybe he has joint pains and all that. That's why he cannot get up from the bed. So the second commonest presentation for stroke is mostly the slurring of speech, about 60%, arm weakness around 65%, facial deviation about 45%. So almost half of our patients have a problem with their face. Then occasionally we have problems with the eyes, visual impairments, the eyes is looking to one side. So apart from the fast mnemonic, there are other mnemonics that try to encompass most of the presentations of stroke. Because stroke affects the brain, and the brain controls almost every organ and every movement, every intention in our body. The presentation of stroke can be varied. Stroke can take any form of presentation. We see stroke that just affects memory. Person is all right a day before. Today, the person gets to work and cannot remember many things. He gets to the office and start fumbling. He doesn't know where he dropped objects, So people will just say, what's going on? This man looks confused or something. So we have strokes that can affect just memory. We have sensory strokes that can affect only sensation or feeling in one part of the body. So there are so many different varied presentations of stroke, but we'll stick to the commonest ones. If we can identify that the patient's face looks uneven, if there is arm or leg weakness, there's problem with speech, there's problem with sight, or there's problem with balance, that really is the time to go to the hospital. If you look at most of our mnemonics, we talk about most of these mnemonics are coming from the developed world. So in their climb, they tend to use, in fact, they will say that it's better for you not to rush the patient to the hospital by yourself because of the way their environment is structured. Most of them use train service and all that. Just call 911. But in our environment, yes, we have ambulance services. Lily Hospital has an ambulance service. You can call us. We can come to your location and get the patient to the hospital safer or safely. But most of the time, patient relation tend to just put the patient into the next available vehicle or motorcycle or tricycle or wherever and get the patient to the hospital. So we work with what is available in our environment.
Hello, Dr. Solomon. Sorry to cut in. We
Yeah.
noticed your slide is not moving.
Oh, yes. Is it moving now?
Not yet. Still the page one.
Oh, okay.
Maybe you would have to reshare. Yes, so you can have it moving. Pause
Am
sharing.
I moving now?
Not yet. I haven't seen your slide yet.
Oh, okay. Let me see if I can stop sharing. Okay, I'm just going to want to reshare. Okay, can you see my slides now?
Yes, we can see it now.
Am I moving now?
Yes, you are, sir.
Oh, okay, thank you. Oh, I'll just complete the presentation without the slideshow. So, in terms of time, so we say time is brain. In every single minute, the brain is made up of billions and billions of brain cells, which we call neurons. So in a minute, whenever we have reduced blood flow to the brain, we can lose up to, the patient can lose up to 2 million brain cells. So this is the reason why stroke is very, very important in terms of timing. So you can imagine within an hour, 3 hours, 6 hours, 12 hours, patient can lose almost 10, 20, 30% of their brain cells. So we keep emphasizing the importance of time. So culturally, we tend to have fears, spiritual thinking, and all that concerning stroke. And stroke itself appears to occur in a spiritual manner. So you have a patient who has quarreled with his neighbor, or they had a family meeting, there was disagreement, or a man that was in some kind of, he wanted to buy a land and there was disputes, the case is in court. So because such persons are thinking, their blood pressure might go up and they might wake up in the morning with a stroke. So everything just looks a little bit spiritual. So our patients tend to, oh, you quarreled with somebody yesterday and today you can't raise up your left hand, or you can't raise up your, so we just we just interpret what has happened to be as a result of the quarrel. So because of that, over time, our patients, patient relations, and culturally in the environment, they tend to associate stroke with something spiritual, or something like maybe the person has done something bad before. This is punishment for what he or she has done in the past. So because of that, people in the community who have stroke, they don't like coming to the hospital. In fact, we have several patients who say, "Oh, doctor, please don't mention it to anybody that I have a stroke." I say, "Oh, but doctors are bound by confidentiality," and all. They say, "No, we know that you are bound. You have your ethical values, confidentiality, and all that. But please, and please, I don't want." There are people that come in, people that are working. They don't want people in their office to know that they've suffered a stroke. So because of that, sometimes they take certain decisions. They might be at home for a longer time. They might call their pastor, or they might go native, other alternative therapy, just to avoid coming to the hospital. Not necessarily that they don't want to come to the hospital, but they don't want to come outside. They don't want people to know. So some even call and say, "Oh, is there home service for stroke? Can we be treated in our home?" I say, "No, it's better you come to the hospital. It's important you come to the hospital." And this is why I'll just quickly talk about briefly recent advances in stroke care. So they'll say, "Oh, what's the point coming to the hospital? There's no treatment for stroke. So there is treatment for stroke, depending on the first thing to do is even to identify what type of stroke. Most of the presentations we're talking about facial deviation, arm weakness, leg weakness, problem of balance, they tend to affect more the ischemic type of stroke. This is the type of stroke that has to do with reduced blood flow. A particular presentation, when the patient complains of severe headache, worst headache, I've never had this kind of headache in my life, tend to affect more of the hemorrhagic type of stroke, which is depicted on your right in the image, in which case the blood vessel artery gets ruptured, it gets burst, and blood is just flowing or gathering, enlarging in the brain, compressing the other normal parts of the brain. So the very first advance in stroke care is quick diagnosis. Quick diagnosis. It's not enough to rush to the hospital. Try to rush the patient to a hospital where there's facility to do a brain imaging. A brain CT scan is the minimum that is required, so that we can know what type of stroke. Is it ischemic stroke, the type of stroke, the problem with blood flow? Is it the type of stroke that the blood vessel is completely burst and blood is flowing in the brain? The treatments are different. So we need to know which type. And this also explains why if you treat a stroke patient in some hospitals where there is no brain scan, the outcome is likely going to be poor. So sometimes they go somewhere and say, oh, they said I should go to the hospital. I rushed to the hospital and my dad is not getting better, my mom is not getting better. Sometimes this is the reason why. They didn't know what type of stroke was affecting the dad or mom. A brain scan was not, maybe after 2 days, 3 days, no improvement. They now say, go to Lily, go and do a brain scan there, or go somewhere, go and do a brain scan. So time has been lost. Brain cells are already dead. So in such a way that you do the scan, now you know the type of stroke, but you have lost so much time to intervene. So quick diagnosis, brain CT scan, go to a hospital that has this facility. It tells what type of stroke. If it's an ischemic stroke, there is a way to improve blood flow to the areas where blood has not been flowing for the past few minutes or the few hours. We call that thrombolytic therapy or endovascular therapy. If it's the other type of stroke that has to do with blood flowing, bleeding, internal bleeding in the brain, yes, there's a way to reverse anticoagulant effect for those that are on anticoagulant. We give reversals, antidotes, protamine sulfate. Sometimes we use vitamin K to reverse what is going on, to reduce the hematoma, which is the blood clot from enlarged. If it's just a small blood clot, the patient is likely to recover 100%. So they might have deficits initially, but after recovery, physiotherapy, they walk around. In fact, they'll say, oh, I had a stroke in 2016. You'll be looking at the man, no evidence of stroke or weakness in him, fully recovered 100%. So that is very important. Other advances in terms of stroke care, we give antiplatelets, we give statin. After identification of risk factor, we try to control the risk factor. Then just a quick one, sometimes after a stroke, because blood does not get to particular areas of the brain, our body tends to increase our blood pressure in response to that, trying to improve the blood flow to that part of the brain. If we don't know the type of stroke it is, some physicians or some doctors or in a healthcare facility, they may be tempted to give blood pressure medications to reduce the blood pressure. That's the wrong time to give that medication, because the body has already sensed that, oh, blood is not flowing to a particular area. Let me increase the blood pressure so that blood flows. And now someone intervenes by reducing the blood pressure. So all this leads to poor outcome. So we need to know what type of stroke are we dealing with in order to manage it appropriately. Then stroke patients are best managed in a stroke ward. This simply means that an area of the hospital where if someone has stroke, Mr. A will also see Mr. B, who has, they do it a lot in large hospitals. They bring people with similar conditions, sometimes to the same clinic. So sometimes they have diabetic clinic, hypertensive clinic, stroke clinic, Parkinson's disease clinic. So when the patient comes there, he now sees a colleague that is someone with similar condition rather, that is on a wheelchair. While he is walking, struggling to walk, he say, oh, it seems that my condition is even a little bit better than other people I'm seeing here. So it's also reassured and motivated, say, oh, so this thing is not only me. So because of that, we like to manage stroke patients together in a designated part of the hospital. So when they are there, their relations see other relations that someone has stroke in the family. So they discuss, they treat this in the hospital. So my dad's son is not so bad after, so they tend to accept it more. So they tend to put back most of their spiritual and cultural beliefs. So that also helps us in terms of the multidisciplinary care. If they are in a particular area in the hospital, the physiotherapist comes in, while occupational therapist coming in, the dietitian comes in, then we get other specialists. Sometimes we need to involve cardiologists if it's a cardioembolic stroke. So we counselors also, we just have a multidisciplinary, and that really helps the patient. Then it's always better to manage conditions where the team are experienced. So if you are running a mini stroke ward or a stroke unit, you tend to have nurses who have seen 1, 2, 3, 4, 100, 200 cases of stroke, 300 cases of, so they anticipate complications that can arise. So they'll know that, there's risk of aspiration here, there will be a problem, this patient may need oxygen. If we continue like this person will develop bed sores and all that. So they've been doing this all the time, every day. So it's usually a lot better managing them in a stroke ward where they get similar care from an expert team. Okay, I think so far maybe we'll slow down here. So this is all about stroke, the importance of presenting early after a stroke, how to recognize stroke. Stroke is one of the easiest conditions to recognize. We often say even by a market woman can diagnose stroke. But what happens after then is very, very important. After you suspect stroke, what do? Do you wait and watch the nerve cells dying every minute that passes by, or do you quickly rush the patient to a hospital, find out what type of stroke, start the right treatment, look out for other complications, bring in the physiotherapist, so if you do all that in an orderly and fast manner, the patient is likely to recover 100% from a stroke. Thank you very much for listening. I will stop here.
Hello, Dr. Solomon. Thank you for taking us through that session. Yes, it was quite, it's detailed on the early warning signs and then the symptoms of stroke. Thank you so much. So very quickly, I would like for us to engage on that which you have, both facilitators have spoken to us about, physiotherapist Chimaobi and then Dr. Solomon, yes, Emagboron. So I would, we already have received 2 questions on the chat box, and we would begin with these questions. Yes, we would begin with these questions. Dr. Chimaobi, I you're there, just to confirm. Physiotherapist Chimaobi, I hope you're there.
Yes, I'm here.
Their concern around the subject. So the first question here is saying someone who is having stroke for maybe Mr. Chimaobi will answer this.
Yes.
Chimaobi.
I saw the question, can someone who is having stroke for 2 years recover back to normal? The answer is yes, and the answer
Yes.
is no. It's both yes and no. Yes, if such individual is highly motivated to embark on an intensive physiotherapy and multidisciplinary team management. Because for your stroke to last up to 2 years means that you have not been following a proper routine management. Or perhaps the severity of the stroke, that's the type of stroke you had, is either hemorrhagic and it was not properly managed. No, in the sense that the type of stroke you have is a very severe type. And two, there are other comorbidities that impairs stroke recovery for one to recover fully. For a young adult, as I earlier said, an adult between 40 to 50 years has more advantage of recovery compared to an elderly person of 60 to 65 and above. This is because other comorbidities like Parkinsonism, like dementia, like having arthritis, having low back pain, and as well vision issue can be a very significant factor that will contribute to the reason why such individual cannot recover back fully. So it depends on the person involved in this case, will determine the level of recovery that is available, whether it's going to be full, back to normal with some deficits available or not. But it's very, very difficult for such individual at 2 years of stroke to recover back to normal. Thank you very much.
Oh, interesting. Thank you so much, sir. So what recommendations would you give to everyone on this call on how to maintain a healthy work-life balance? Because we have our daily routines that takes us from 8 a.m. to 5 p.m. and then we go back home and just take our rest and then return back again. What would you recommend healthy tips so that people who have a likelihood to come into such experiences will begin to take precautions? Dr. Solomon, you're here. Maybe I would like that you also speak to this as well. Okay? So you just give recommendations generally. Thank you.
Okay. So in terms of recommendation, first of all, we say maintain a healthy lifestyle. Yes, if once we are close to 40 or we get to 40, we need to be more conscious of our health. So often, depending on the organization, some organizations do health check or annual medical checkup. So that helps to, if your organization is not doing that, sometimes churches and other groups do health week and all that. So people in the community should try to participate. They'll be able to identify risk factors, hypertension, diabetes, cholesterol, obesity. So once these risk factors have been identified, they should try to do lifestyle modification. If it's not working, healthy eating, try to avoid salt, weight loss. So if it's not working, really, you need to see your family physicians, discuss with them. They might place the person on medications, try to stick to this medication. Yeah, so sometimes people go to that extent, they take the medications. After a while, they say, oh, my blood pressure is now controlled. I don't think I need these medications again. So they stop. So most of the time, our patients are already aware that they are hypertensive or diabetic, but along the line, maybe the blood pressure gets okay, or they get advice from other relations. They go and seek alternative care. So that's really where we tend to have problems. So someone that is healthy can maintain a healthy lifestyle and remain in good health. If for one reason or another, yeah, so we tend to say hypertension is essential. Hypertension is very common. Most people don't uh, realize that hypertension is very common. So they all say, oh, my blood pressure went up at some point. So most of the time we're often in denial. So that's usually what puts us in all these problems. Say, oh, it went up that year when I was pregnant, then it went back to normal. But are you checking? Are you monitoring it? Do you check once in a while? When your doctor prescribes medication for you, do you stick to it, or do you say, oh, it has come down now, there's no need for me to take it again? Or do you take alternatives? So this is really where we have problems in terms of compliance. Yeah. Thank you.
Solomon, I have questions already on the chat box. I'll quickly read up them and then we begin to engage them some more. So someone is asking, what is the first line of action that can be given to an individual who has suffered a stroke in a remote location where there's no nearby healthcare facility? So she came across a video where a man was dancing and then he suddenly just struck down. And peradventure you are in that kind of situation or that kind of experience. How do you quickly seek for medical attention?
All right, I saw this question. I was about responding to it too. Okay, a lot of factor from the scenario she gave, a lot of factor can struck someone down in that scenario. This can be a case of cardiac arrest. That's where the BLS we did came in or have to be employed if it's a case of cardiac arrest. But if it's a case of stroke, in a remote environment, the first thing I would recommend is safety. You have to ensure that this patient is safe. Say, for instance, this individual fell on the ground. You don't just abandon him or her. You have to position the patient in a sideline, in a comfortable lying position. Ensure the person is breathing. Ensure the person is communicating, like is responsive. Okay? Then from the reaction, from the response you get, will give you a clue if there is a snore speech or a form of confusion, or noticing that the limb is weak, that is a particular limb is weak. This will be a sign of stroke for you to identify. Then, as this has happened in a remote area, unfortunately, there is no hospital around or any health care facility around. I will advise at this moment is to make an arrangement to find your way to any nearby health care facility. It may be far from the environment, may be far from the remote place, but there is immediate need to reach the hospital and confirm the root cause, what really happened. With an MRI or CT scan of the brain, we'll be able to ascertain exactly what is going on with such individual. But unfortunately, some people resort to make it to traditional way, and eventually, if it is hemorrhage that is bleeding that is going on in the brain, maybe it will take them 2 to 3, 4 days to arrive in the hospital. You see, more damage has been caused. So it is always ideal that in any case of health-related issue, whether it's in the remote or town, there should be alternative plans to take the person to any nearby healthcare facility. That would be my recommendation.
Yeah, I quite agree. Just coming in here from the physician point of view, most of the time we say first, do no harm. So you really have to know what you are doing. You can't just manage the patient. If you don't have information, you don't have lab to help you, you don't have imaging. Yeah, so what are you treating really? So, and that will also put you at risk of litigations and all that, you know. So the relations can come back in a month's time and say, oh, you are the cause of the delay, assuming you had advised them or they had made the arrangements, maybe our grandpa or our dad would have survived. You understand? There are some variations to this question. Sometimes they'll say, oh, the person refused to come to the hospital, that he wants to be treated at home, or that he doesn't believe it. So by the time you try and convince and you are not getting a headway, sometimes, so somewhere in the literature, because ischemic strokes, like the stroke that has to do with reduced blood flow, makes up the vast majority, about 85%. The person is not unconscious. It looks like a stroke, but the person can still communicate to an extent and all that. So sometimes we say, if you are a medical officer, you don't have access, you don't have immediate access to move the patient to a facility where they do a brain CT scan. The patient is conscious. You may be able to judge, score, and say, oh, this looks like ischemic stroke. So you treat in line with ischemic stroke. But really, in 2013, stroke definition is based on neuroimaging. If you are going to help somebody, yeah, you need to know what's going on. Is it a clot? Is it a bleed? You just need to know. Otherwise, the help that you rendering may be harmful to the patient. Thank you.
Thank you, Dr. Solomon and Mr. Chimaobi, for bringing that light. I hope that the person who has asked that question gained clarity on that. Okay, so the next question I'm about to read up, I've also seen a post around this before now, where there's a particular doctor was giving advice to people, right? Especially people who could have the tendencies of getting into a stroke experience. And then he said that it's been proven that for old people, that it's preferred that when they're about to take their bath, you don't pour water from your head down. That the first step, so that, and that's the reason for a lot of a high experience of stroke victims, right? That people with high the occurrence of stroke many times begins from the bathroom with old people, and he was advising that it's preferred that if you have such kind of likelihood, you should begin by pouring water from your feet down to your head. So it brings me to the question that over the years, there's been many cases of strokes occurring in the bathroom. Please clarify the reason behind this. I'd like to get our position on and recommendation on that stuff. Thank you.
Okay. Well, if you look at the pathophysiology, yeah, cold water tends to cause vaso constriction. So what that means is that our blood vessels get stiffer and more rigid. So cold water, the blood pressure may slightly go up, but that should not cause a stroke, except maybe the person already is hypertensive and his blood pressure is not controlled, you know. So if my blood pressure is 190 or 200, then you frighten me, you give me some kind of shocking news, or you pour cold water on my body, yeah. So it may go up from 200 to 210 or 220, yeah. So there is that risk that sudden rise in blood pressure can cause a stroke. Yeah, warm water also is, we say just use the lukewarm water because the water is too warm or too hot. Yeah, that one can cause vasodilation, so the blood pressure can drop suddenly. And elderly people, maybe their blood pressure is 100 over 60, and they use warm water or hot water, the blood pressure can drop. And if our blood pressure drops, high blood pressure can cause stroke, same as very low blood pressures can also result in blood not flowing in important areas of the brain. So that's also a cause of stroke. So yes, issues around the bathroom, yes, they can be stroke. Then the other issue we have in the bathroom, uh, people, apart from taking their bath, they also use the toilet. Sometimes they micturate, they pass the urine, and we have what we call a micturition syncope. While we're passing urine, our blood pressure tends to drop a little. So if it drops too much, or an elderly person maybe is not taking enough fluid, elderly people, they hardly drink water, isn't it? So maybe it's not taking enough fluid, he already has borderline low blood pressure. So sometimes they say, mama is waking up in the night 2, 3 times to go and wee. Watch her very well. You know, there are so many risks waking up to go and pass urine, micturition, syncope. Then there are also other risks. The bathroom floor may have water, might be slippery. Elderly people, they have problem with sight, so they might easily slip and fall. Then again, we say blood pressure is highest due to stress response. Cortisol hormone, counter-regulatory hormone, is secreted highest when we sleep. So typically, our blood pressures tend to be slightly higher around 3 a.m., 4 a.m. in the morning. So most of the time, that's when our patients have strokes. So a patient with a blood pressure borderline about systolic of about 180, 190, not taking his medication, it goes up uh, around 4 a.m. to 200. So we tend to have what we call a wake up stroke. So many problems around night time, bathroom, and waking up with a stroke. Thank you.
Okay, thank you, Dr. Solomon. Mr. Chimaobi, do you have a position on this? Well, I think it's clear. Let's just move on to the next question. Can recurrent migraine be a sign of stroke, Dr. Mr. Chimaobi? Can recurrent migraine be a sign of stroke? Also, just to add to that question, can severe vibrating sensations in the head be a sign of neurological conditions? Neurological condition? This prevents the patient. Okay. So this prevents the patient from sleeping, carrying out daily activities, accompanied with severe weaknesses and sensations associated with the limbs. So we'd like you to speak on this, doctor.
Okay. Okay. So migraine is a type of one-sided, mostly one-sided headache. So migraine is not a stroke, but migraine has to do with also changes in blood flow to the brain. So our patients that are having migraine, in fact, there's a form of migraine that is called the hemiplegic migraine, in which case blood flow is altered to particular areas of the brain. It results in a headache. And like we said, stroke is just about reduced blood flow. So if there is reduction in blood flow, it could cause a headache and weakness on that side of the body. But reduced blood flow is not enough to cause a stroke. There has to be a reduction in blood flow. In addition to that, there have to be cell death. So the nerve cells or part of the brain has to die before we say, oh, this is a stroke. If there's just reduced blood flow, the limb is not working, there's a headache. So this is the reason why we say the person should come to the hospital if we're able to identify that, oh, there's migraine, reduced blood flow, the patient is rehydrated, the patient will recover 100%. And the same thing that occurs in what we call transient ischemic attacks, in which blood flow to particular areas of the brain is reduced. You identify it in time, maybe the person collapses, is rushed to the hospital, is treated. So you hear them saying, oh, I almost died yesterday, if not for people that rushed me to the hospital. So those ones are transient. Those are not strokes. For a stroke to occur, cell death, part of the brain, a few nerve cells or many have to die. Other nerve cells that are alive have to take over the function of the area that is infected or the area that is dead. Yeah, so migraine, no, not a sign of stroke, but a form of migraine can present like stroke. So that will be completely reversible almost within a day. Most strokes are reversible, but it will take a longer time. We need help from physiotherapy and all that to recover function. Vibrating sensations in the head. Yeah. So we said stroke, the brain does a lot of function, memory, movement, including sensation. So the brain also controls the heart, the lungs. So yes, in terms of sensation, the brain also does that. There are areas of the brain that control sensation. The thalamus, for example, controls pain sensation. So yes, we can have abnormal sensation, vibrating sensation if there is involvement of thalamic basal ganglia areas. So yes, the patient, it can be a presentation of stroke. It can also be a presentation of other neurological conditions like dementia. So sometimes we say dementia is not a stroke, but it's like small stroke, like small area of the brain not getting enough blood supply. Tomorrow, another small area of the brain not getting, but it doesn't occur suddenly all at the same time. So it just creeps up on us. 6 months pass, a year pass, 2 years pass. So we just notice that our elderly ones, grandma, when you visit grandma, she cannot recall your children's name, or she cannot recall your name again. Say, mama, my name now Solomon. You remember? Oh, na me be Onajite. So you try to remind her. So what's going on is over time, grandma may have been having small areas of her brain, so tiny strokes, what we call lacunar infarct. So because the area is so small, it's not so obvious to people that, oh, grandma had a stroke. The one that is obvious is if it's a large area, then she wakes up in the morning, she cannot remember where she is. So it's obvious to everybody. But if it comes up slowly, yeah, they may not be able to remember. Then they complain of funny complaints, symptoms. Say, they feel something moving in their head, they feel vibration in their head, they can't sleep. So these are the effects of tiny strokes that have occurred over time. So because of that, the brain, the areas of the brain are affected. Some areas are not functioning again. So the brain starts to shrink. So the capacity of the brain, things that she can do before, she's not able to do. After a while, apart from problems sleeping, they now, yes, it's stated in the question, they have problem carrying out daily activities. So grandmother used to go to the market before. She gets to the market, she cannot calculate. She loses money. Then the relations say, mama, you know, go feed they go market again. The money where they go, they lost them. So she can't carry out all those normal activities again. She can't go to ATM again. She cannot remember her PIN and so many things. So these are effects of cumulative small, tiny lacunar strokes over a lifetime. Thank you.
We're about bringing this to a close. Let's say the next 10 minutes, we should bring this to a close. Okay, I have several other questions here. But before we go on to reading the questions on the. I'd like to check, are there support groups, right, for rehabilitating patients who have suffered from stroke? And also, how do we assess our rehabilitation services at the Physio Center?
I didn't get your question.
Thank you. Yes, should there be support groups people who are
Your voice is breaking.
assess our rehabilitation service?
Can you repeat the question again? I couldn't get you.
So my question is, are there support groups that helps to take people through who have suffered this kind of experience, a stroke experience? Are there support groups that helps lead people through, take people out of these experience? And then also, how do people assess our rehabilitation services at the wellness center?
All right, thank you very much. Yes, there is a lot of support group, and currently we even have one in Lily Hospital. We have one called Lily Wellness Center Support Group. We call it Escape Stroke Network. Okay, it's Escape Stroke Network. It's a combination of physiotherapists, occupational therapists, speech therapists, that's social workers. We look into the, especially when we're on a home service program. We need to adapt your home. We need to put you through speech therapy process, and we need to work with the neurologist. Is a multidisciplinary team effort. We have one at the center because it's not just only stroke that we manage at Lily Wellness Center. We also manage other neurological conditions that also requires this group support. So if there is a memory issue, like the person is having dementia, tackling the issue of memory, we partner with some memory clinic that will help in that regard. Then if it's a group exercise that is needed for individuals with Parkinsonism, we also arrange such in our center. So for more clarification, such individual can visit our center at 18 Deco Road and access more information in this regard.
This is very, very exciting to hear. At least we could talk about this to people who would want that kind of network. All right. I'm really glad to hear this, Mr. Chimaobi. Thank you for just bringing in a word in that direction. All right. So I'll take the last two questions here, and I think we'll be bringing this session to a wrap. Okay. So maybe I'll begin with Dr. Solomon. I'll begin with you, Dr. Solomon. What is the best clinical or pharmaceutical management of stroke, e.g., the person noted like IV fluids and medications? I hope this is clear.
Yes, in terms of the best fluid, the fluid of choice, the intravenous fluid of choice is normal saline. So it's an isotonic fluid. So for a patient having a stroke, areas of the brain are not perfused. This simply means that blood is not reaching particular areas of the brain. So yes, so since it's an isotonic fluid, it tends to remain in the intravascular, remains with the blood. So the blood volume increases. in a way. So with that increase in volume of blood, there is slight increase in pressure. So a particular area that is partly blocked by a clot, the clot can be dislodged. So normal saline is the best fluid to use. Most of the time for people that are placed on dextrose water, usually once the patient comes into our care, we change to normal saline. Sometimes other healthcare practitioners are worried. They say, won't the normal saline increase the blood pressure more? Yeah, we want the blood pressure to go up a little higher. If you are living in the top floor, maybe third floor or fourth floor, and you open your tap and the tap is not running, or it's just dripping or the dropping some water, you ask, maybe you need to on the pumping machine, maybe the tank needs to be filled. You are trying to increase the volume in the tank so that the pressure can come up, so that the brain cells will not be starved of oxygen and other glucose and other requirements. So to help them survive. So yes, normal saline is a fluid of choice. In terms of medications, it depends on the type of stroke. For ischemic stroke, usually we say the tenecteplase, alteplase. So these are thrombolytic agents are the best. If they are not available, we use streptokinase. If that's still not available, we tend to use vasopressin, which is soluble aspirin or clopidogrel. So those are our choices based on the type of stroke. Then for strokes that involve hemorrhage or bleeding, we give antidotes such as vitamin K or protamine sulfates. Yeah, so we do that. Other places, they also give fresh frozen plasma and all that. So there are several interventions depending on the, so that just goes again to say the management will depend on what you are able to identify in terms of stroke type. I was just briefly looking at this other question. So it's similar to what we're trying to explain. There's a family friend of mine over 70 years, has never had a stroke to the best of. So yeah, from my experience, this family friend, 70 years, has had multiple strokes. So really, since they are occurring lacunar strokes, small, tiny strokes, so it will not be obvious to the relations, isn't it, or to other people. So there's no particular day that it looked like she had a facial deviation or weakness, but patient might have been having tiny strokes over the years. So depending on the area that it's affected, after a time, after a long period of time, what we call multi-infarct dementia. So after a long period of time, all those small strokes will now appear as a large stroke, so which will now affect so many areas of our brain in terms of coordination. All of a sudden, you now look as if she can't move her upper limb, she can't move the lower limb. She cannot even speak, as speech is slurred. Mama, stand up. Mama is unable to stand up. So it accumulates over time. So they call it multi-infarct dementia. So over time, it now looks like, yeah, when you take her to see orthopedic surgeon, orthopedics, of course, they'll say, no, we don't think there's anything wrong with her joint. This looks like a neurologic condition, because for a neurologic condition, you see multiple domains affected. If I'm just having problem with my joints, I'll be talking, I won't be able to give a lecture. It's just that after the lecture, when I try to get up, I'll scream, my knee is paining me here. But if mama is not able to communicate well, she's not able to stand, so it looks a little bit more than just problem of our joints. So it's likely neurologic. Thank you.
Thank you so much, Doctor. Okay. So the last question here is, what's the golden hours in stroke treatment? What's the golden hours in stroke treatment? Mr. Chimaobi, would like to hear you now.
All right. The golden hours in stroke treatment is the moment the stroke happens is the golden hour to start to initiate stroke treatment. That is where the medical team will come in to stabilize the patient. What I mean by medical team stabilizing the patient is to arrest what is causing the stroke exactly. Is it as a result of clots, that's ischemic stroke is happening, that a fat or something is blocking blood from flowing to the brain? So the golden hour is at that moment it's starting to unlock it, to block it and allow blood flow back. Then if it is hemorrhagic stroke, as at the onset of that stroke, it's time to start giving the blood lysis, things that will arrest the bleeding of the brain, because the more the bleeding is going on, the more the severity of the stroke. So having arrested that stroke at that golden hour, then physiotherapy comes in for restoration of function. Thank you very much.
Dr. Solomon, would you want to add to that, or we're good?
Yeah, basically we're good. So every, if you think about it, like every minute, the person is going to lose 2 million brain cells. Yeah, so really, we should be talking about golden minutes or golden seconds. But if you are looking at the literature, most of the medications, we say try to give within the first 4.5 hours. So really, within the first hour will just really be best. In fact, sometimes they use times, in other clients, they use times to score the hospital. Okay, you saw 100 stroke patients. How many of them were you able to do your brain CT scan within 30 minutes? They came to your facility. So they use that to score and grade hospitals in other clients. So they now say, okay, this is a stroke ready hospital. This is a stroke center. So if you are able to do that and give your medications very fast, so they will label your hospital as a stroke center. So if someone is having a stroke in the community, they'll say, oh, send to Lily Hospital. Then for other hospitals that maybe they are not able to meet up with that time, they will not label them as stroke center. They will say they are not stroke ready. So that's how they, yeah. So we are yet to get to that kind of level in our environment yet. But really, time is brain, very very important.
Thank you so much, Dr. Solomon. Just as we bring this session to a close, I just want to highlight something very important you spoke about, and have us, yourself and physiotherapist Chimaobi, just bring a general word to us briefly. But before we do that, I'd like to just bring to mind something you spoke about, and I think will be beneficial to everyone on this call. You spoke about identifying the risk factors, right, for a likelihood of stroke. And you spoke about our cholesterol levels, obesity, weight loss, diabetes, and having to check our alcohol consumption rates, knowing the genetic factors, and then some other points you spoke about. I think it's important that we give attention to these things as a way of managing the likelihood of stroke experiences. Yes, that's the point I just want to bring to everyone. And then, Dr. Solomon, I would like for you to bring a final word and a conclusion to that which we have shared today, and a point of advice, or a point of advice to everyone. And also, Mr. Chimaobi would like that you also do same as we bring this discussion to a close. Thank you. Dr. Solomon, maybe you'll be.
Okay, so I would just like to say that, yeah, stroke can be frightening. Stroke in younger people is we usually say it's a disaster. because most of the time younger people are the breadwinners. So you can imagine stroke occurring in working class adults. So yeah, there are ways to identify the type of stroke. There are effective treatments for stroke. So the message I would like us to take back, especially to our relations or communities, yeah, since stroke can be identified and effectively treated with the help of physiotherapists, patient can be rehabilitated. We urge people to come to the hospital when they notice or when they are able to recognize that, oh, they are having a stroke, so that they can fully recover and go back and live their normal life. Thank you.
Thank you, Doctor. Mr. Chimaobi, please.
All right. My final words to everyone is to always remember that the same manner we have road accidents is the same way we have brain incidents, and that's where stroke occurs. It is not the end of life if you employ the right attitude, if you embrace the right health-seeking behavior of coming to the hospital immediately or bringing your relative or your family that have stroke for stabilization, and immediately embark on physiotherapy rehabilitation. We work conservatively as a multidisciplinary team. While we encourage you in this journey, we are hopeful that if you comply with the necessary techniques that we outlined during the presentation, you have a good prognosis to come back to form and function and carry on with your daily activities. Thank you very much.
Thank you so much, Mr. Chimaobi and Dr. Solomon. Quite an engaging and insightful session. And I want to thank everyone who stayed through the call as well. You know, we have an obligation to ensure that as a health organization, we are dedicated to your well-being. Hence, such sessions are coming up. We look forward to subsequent ones that will be happening in no distant time. Thank you once again. So I would like to also mention that there's an upcoming webinar. This will be happening on Friday, the 31st of May, which is next week Friday. Okay, and it's going to be directed to the ladies in our midst. Okay, it's going to be of great interest to women, those who are pregnant and those who are planning to start a family, right? We're going to be looking at, we're going to be having a talk around eating well for two, okay? So those who are intending to get into the family life and those who are pregnant, this will be of great interest to you. And our dietitian, Olatunde Olufumilayo, is going to be taking us on that discussion. We're going to be looking at cravings, aversions, food safety, and the likes during pregnancy. That session is going to be happening by 10 a.m. on Friday, the 31st of May, 2024. Do well to let your friends, your family members as well know this. We believe that it's going to be another very beneficial and impactful session. Once again, I want to thank you all. Do well to reach out to our wellness center. Mr. Chimaobi is there leading the team, and then we have our consultant neurologist, Dr. Solomon. If you have need or if you observe or have concerns around the subject has been talked about. I want to wish us all a very beautiful and safe working day. Thank God it's Friday. Bye for now, everyone.
Everyone.
Bye.